Question 1. A client in active labor is receiving oxytocin, pitocin, infusion. Which finding requires the nurse's immediate action? A. Contractions every 3 minutes, lasting 60 seconds. B. Fetal heart rate 150 bpm. C. Contractions every 90 seconds, lasting 90 seconds. D. Uterine resting tone 15 mm of mercury. Answer, C. Rationale: oxytocin overdose causes uterine hyperstimulation, reducing placental perfusion and leading to fetal hypoxia. Strategy tip: always prioritize fetal distress and uterine tachysystole as danger signs during oxytocin infusion. Question 2. A postpartum client receiving methylergonavine, Methergine, has a blood pressure of 168/98 mmHg. The nurse should A. Administer as ordered. B. Hold the dose and notify the provider. C. Reassess BP in 30 minutes. D. Document and continue observation. Answer, B. Rationale: Methergine causes vasoconstriction and is contraindicated in hypertension or preeclampsia. Strategy tip: always check BP before giving Methergine. Question 3. Which laboratory finding is most critical to assess before giving magnesium sulfate for preeclampsia? A. Potassium. B. Calcium. C. Creatinine. D. Sodium. Answer, C. Rationale: magnesium is excreted renally, impaired kidney function increases risk for toxicity. Strategy tip: think kidneys before magnesium. Question 4. The nurse is monitoring a client on magnesium sulfate. Which sign indicates toxicity? A. Deep tendon reflexes +2. B. Urine output 45 ml per hour. C. Respirations 10 per minute. D. Fetal heart rate 130 bpm. Answer, C. Rationale: respiratory rate less than 12 per minute equals magnesium toxicity. Strategy tip: if respiratory depression or absent reflexes appear, stop infusion and give calcium gluconate. Question 5. A client in preterm labor receives terbutaline, breathine. Which finding requires urgent attention? A. Maternal pulse 122 bpm. B. Blood glucose 110 mg per deciliter. C. Mild tremor. D. Uterine relaxation. Answer, A. Rationale: terbutaline causes tachycardia, HR 120/130 equals risk for cardiac complications. Strategy tip: always check pulse before giving terbutaline. Question 6. Betamethasone is administered to a client at 32 weeks gestation in preterm labor. The expected therapeutic effect is A. Stimulation of contractions. B. Prevention of infection. C. Acceleration of fetal lung maturity. D. Decrease in uterine irritability. Answer, C. Rationale: betamethasone increases surfactant production to reduce neonatal respiratory distress syndrome. Strategy tip: remember, B for betamethasone, B for baby's breathing. Question 7. A nurse prepares to administer Rho-D, immune globulin, Rhogam. Which statement is correct? A. It is given to Rh-positive mothers. B. It is given to the infant. C. It is given to Rh-negative mothers after Rh-positive delivery. D. It is given before every pregnancy. Answer, C. Rationale: Rhogam prevents maternal sensitization by neutralizing Rh-positive fetal RBCs in Rh-negative mothers. Strategy tip: think negative mom, positive baby. Question 8. A nurse is teaching about ferrous sulfate for anemia in pregnancy. Which statement indicates correct understanding? A. I should take it with milk. B. I should take it with orange juice. C. I can take it with antacids. D. I should take it on an empty stomach. Answer, B. Rationale: vitamin C enhances absorption, calcium and antacids decrease it. Strategy tip: iron plus C equals absorption boost. Question 9. A postpartum patient taking carboprost-tromethamine, Hemabate, complains of shortness of breath. What should the nurse do first? A. Document the finding. B. Give oxygen. C. Stop the medication and notify provider. D. Reassure the client. Answer, C. Rationale: Hemabate can cause bronchospasm, contraindicated in asthma. Strategy tip: Hemabate equals breathe, asthma equals wait. Question 10. A client with postpartum hemorrhage receives oxytocin and misoprostol, side attack. The nurse understands A. Both cause uterine relaxation. B. Both cause uterine contraction. C. Misoprostol causes vasodilation. D. Oxytocin reduces BP. Answer, B. Rationale: both drugs promote uterine contraction to reduce bleeding. Strategy tip: Cytotec contracts the cervix and uterus. Question 11. Which adverse effect of magnesium sulfate must be reported immediately? A. Nausea. B. Flushing. C. Absence of patellar reflexes. D. Warm sensation. Answer, C. Rationale: loss of DTRs equals early toxicity. Strategy tip: remember MAG equals muscle aches gone, no reflexes. Question 12. Before administering dinoprostone, Cervidil, for cervical ripening, the nurse should assess A. Cervical dilation. B. Membrane status. C. Fetal station. D. Fetal heart rate. Answer, D. Rationale: fetal monitoring must be established before prostaglandin induction to detect distress. Strategy tip: always assess baby before the drug. Question 13. Hydralazine is ordered for a preeclamptic client. What is its primary effect? A. Decreases uterine contractions. B. Increases cardiac output. C. Lowers blood pressure. D. Promotes diuresis. Answer, C. Rationale: hydralazine is a direct vasodilator used to manage severe hypertension. Strategy tip: hydra equals hydrate vessels equals dilate. Question 14. A nurse should question which order for a patient receiving magnesium sulfate? A. Continuous FHR monitoring. B. Calcium gluconate at bedside. C. NPO status. D. Administration of nifedipine concurrently. Answer, D. Rationale: both cause smooth muscle relaxation risk of severe hypotension. Strategy tip: never mix mag plus nifedipine. Question 15. Which statement by a postpartum client taking stool softeners, docusate sodium, after episiotomy shows understanding? A. This will prevent constipation and straining. B. I can stop when stools are hard again. C. It will cause diarrhea. D. It increases peristalsis aggressively. Answer, A. Rationale: docusate softens stool without stimulating contractions, safe for postpartum. Question 16. A G2P1 at 39 weeks receives misoprostol, Cytotec, vaginally for induction. 2 hours later she reports severe abdominal pain and FHR decelerations. The nurse's first action is A. Give 4 morphine for pain. B. Remove the vaginal tablet and notify provider. C. Start oxygen and position on left side, then continue to monitor. D. Document findings and reassess in 15 minutes. Answer, B. Rationale: prostaglandin vaginal tablets can cause uterine hyperstimulation and fetal distress, remove immediately. Strategy tip: if induction agent placed vaginally, remove if hyperstimulation or fetal distress occurs. Question 17. A laboring patient on oxytocin develops uterine tachysystole with late decelerations. The nurse should A. Increase oxytocin rate to improve progress. B. Stop oxytocin, reposition, give oxygen, and notify provider. C. Administer terbutaline to augment contractions. D. Continue monitoring, this is expected with oxytocin. Answer, B. Rationale: stop the infusion to reduce uterine tone, improve placental perfusion, implement intrauterine resuscitation. Strategy tip: tachysystole plus late decels equals stop oxytocin now. Question 18. Which medication is contraindicated in a client with active asthma being treated for postpartum hemorrhage? A. Oxytocin. B. Methylergonavine, Methergine. C. Carboprost, Hemabate. D. Misoprostol, Cytotec. Answer, C. Rationale: carboprost, a prostaglandin F2 alpha, can cause bronchospasm, avoid in asthma. Strategy tip: asthma plus Hemabate equals red flag. Question 19. A woman in preterm labor at 29 weeks receives indomethacin as a tocolytic. The nurse should monitor the fetus for A. Polyhydramnios, B. Premature ductus arteriosus constriction and oligohydramnios, C. Increased fetal movements, D. Fetal macrosomia. Answer, B. Rationale: indomethacin, a prostaglandin inhibitor, can prematurely close the ductus arteriosus and decrease fetal urine output oligohydramnios. Strategy tip: limit indomethacin use to early preterm and brief duration. Watch amniotic fluid and ductus. Question 20. A patient receiving magnesium sulfate has a urine output of 20 milliliters per hour for 3 hours. The best action is A. Continue infusion, this is expected. B. Increase infusion rate. C. Hold infusion and notify provider, risk of toxicity due to low renal clearance. D. Encourage oral fluids. Answer, C. Rationale: low urine output increases magnesium retention and toxicity risk, stop and notify provider. Strategy tip: urine output less than 30 milliliters per hour is concerning during magnesium therapy. Question 21. Which medication is given to reverse magnesium sulfate toxicity? A. Naloxone, B. Calcium gluconate or calcium chloride, C. Protamine sulfate, D. Vitamin K. Answer, B. Rationale: calcium gluconate is the antidote for magnesium toxicity. Strategy tip: if RR depressed, absent reflexes, or cardiac instability, stop mag and give 4-calcium. Question 22. A preeclamptic patient on magnesium sulfate develops absent patellar reflexes and respiratory rate of 8 per minute. The nurse should A. Increase the magnesium infusion. B. Stop magnesium infusion immediately, prepare calcium gluconate. C. Administer a bolus of oxytocin. D. Encourage deep breathing. Answer, B. Rationale: absent DTRs and RR less than 12 indicate severe magnesium toxicity, stop infusion and give calcium. Strategy tip: DTRs and RR are the fastest bedside toxicity checks. Question 23. A newborn receives erythromycin ophthalmic ointment after delivery. The purpose is to A. Prevent neonatal conjunctivitis from gonorrhea/chlamydia. B. Provide vitamin A. C. Prevent neonatal sepsis from group B strep. D. Sterilize the eyes for cosmetic reasons. Answer, A. Rationale: erythromycin ophthalmic prevents ophthalmia neonatorum from N. gonorrhea and partially chlamydia. Strategy tip: mandatory prophylaxis in many hospitals, apply within an hour of birth. Question 24. A breastfeeding mother asks whether she can take ibuprofen for postpartum pain. The best response: A. No, absolutely contraindicated. B. Yes, ibuprofen is compatible and preferred for breastfeeding pain control. C. Only if infant is 6 months. D. Only in topical form. Answer, B. Rationale: ibuprofen is generally safe and preferred for lactating mothers due to low infant exposure. Strategy tip: use NSAIDs like ibuprofen cautiously, but they are lactation friendly. Question 25. Which antihypertensive is often used in severe preeclampsia intravenous management? A. Lisinopril, B. Hydralazine or labetalol, C. Spironolactone, D. Atenolol. Answer, B. Rationale: for hydralazine or for labetalol are commonly used for severe hypertension in pregnancy. ACE inhibitors, lisinopril, are contraindicated. Strategy tip: ACE inhibitors/ARBs equals contraindicated in pregnancy. Question 26. A woman who tested hepatitis B surface antigen positive at labor should have her newborn receive A. Hepatitis B vaccine only at 2 months. B. Hepatitis B immune globulin, HBIG, and hepatitis B vaccine within 12 hours of birth. C. No treatment required if mother asymptomatic. D. Oral antiviral for the baby. Answer, B. Rationale: Newborns of HBsAg-positive mothers should receive HBIG plus Hep B vaccine within 12 hours to reduce infection risk. Strategy tip: timing, within 12 hours, is crucial. Document administration time. Question 27. A client receiving nifedipine for tocolysis complains of headache and facial flushing. What should the nurse suspect? A. Allergic reaction. B. Side effects of vasodilation from nifedipine, calcium channel blocker. C. Magnesium toxicity. D. Preeclampsia worsening. Answer: B. Rationale: nifedipine causes vasodilation leading to headache, flushing, common side effects. Strategy tip: monitor BP, avoid combining with magnesium for additive hypotension. Question 28. A woman on long-term oral progestin-only contraception is being counseled about lactation. Which is correct? A. Progestin-only methods are acceptable during breastfeeding and do not suppress milk significantly. B. All hormonal contraceptives must be stopped during lactation. C. Combined estrogen-progestin pills are preferred while breastfeeding. D. IUDs are contraindicated while breastfeeding. Answer: A. Rationale: progestin-only methods are generally safe in breastfeeding. Estrogen-containing contraceptives may reduce milk supply. Strategy tip: offer non-estrogen methods postpartum if breastfeeding. Question 29. A patient in labor receives nalbuphine for pain. The newborn is born 30 minutes later and has respiratory depression. The nurse knows nalbuphine A. is a partial opioid antagonist that can cause neonatal respiratory depression if given close to delivery. B. is safe and has no neonatal effects. C. is reversed by naloxone in the mother only. D. stimulates neonatal respirations. Answer: A. Rationale: opioid agonist-antagonists given close to delivery can cross placenta and depress neonatal respirations. Naloxone may be required for the infant. Strategy tip: avoid giving systemic opioids within 2 to 4 hours of expected delivery when possible. Question 30. Which drug is used to treat maternal Rh sensitization, isoimmunization, in an Rh-negative mother after invasive procedure or delivery? A. Magnesium sulfate. B. Ro. D. Immune globulin, Rogam. C. Oxytocin. D. Erythromycin. Answer: B. Rationale: Rogam prevents maternal alloimmunization when Rh-negative mother exposed to Rh-positive fetal blood. Strategy tip: administer within 72 hours postpartum or after sensitizing events, amniocentesis, bleeding. Question 31. A mom received methylorgonavine for uterinotomy but has chest pain and shortness of breath. What should the nurse suspect? A. expected side effect, reassure. B. ergodalkaloid-induced coronary vasospasm, hold drug and notify provider. C. allergic reaction, give epinephrine. D. pulmonary edema from oxytocin. Answer: B. Rationale: methylorgonavine can cause severe vasospasm, including coronary vasospasm. Chest pain is alarming. Strategy tip: contraindicated in hypertension and ischemic heart disease. Question 32. A patient receiving terbutaline for tocolysis develops chest tightness, irregular pulse, and palpitations. The nurse should: A. continue infusion, this is normal. B. hold drug and notify provider, possible maternal tachyarrhythmia. C. give calcium gluconate. D. start oxytocin. Answer: B. Rationale: terbutaline can cause maternal cardiac tachyarrhythmias, stop and notify. Strategy tip: terbutaline use for tocolysis is time-limited and requires cardiac monitoring. Question 33. A patient receiving oxytocin asks why the infusion is titrated slowly. The best explanation: A. to avoid uterine rupture, tachysystole, and fetal hypoxia by controlling contraction frequency/intensity. B. because oxytocin takes days to work. C. to cause hypotension gradually. D. to prevent thromboembolism. Answer: A. Rationale: slow titration reduces risk of hyperstimulation and fetal compromise. Strategy tip: monitor contraction pattern and FHR continuously during titration. Question 34. Which of the following is a contraindication to giving methylergonavine postpartum? A. Atonic uterus after vaginal delivery. B. Elevated blood pressure, e.g., 160/100. C. Minimal lochia. D. Uterine inversion. Answer: B. Rationale: methylergonavine is contraindicated in hypertension due to vasoconstrictive effects. Strategy tip: check BP before each dose. Question 35. A laboring patient is receiving pneumococcal vaccine counseling during pregnancy. The nurse should say: A. It's contraindicated in pregnancy, never give. B. Vaccines with inactivated components may be given if indicated, live vaccines are contraindicated. C. All vaccines are okay in pregnancy, including live attenuated. D. Vaccines are unnecessary in pregnancy. Answer: B. Rationale: inactivated vaccines recommended when indicated, e.g., influenza, Tdap, live vaccines, MMR, are contraindicated. Strategy tip: Tdap in each pregnancy is recommended to protect newborn from pertussis. Question 36. A postpartum patient with severe postpartum hemorrhage is given tranexamic acid, TXA. The primary goal is to A. Cause uterine contractions. B. Promote clot stability by inhibiting fibrinolysis. C. Lower blood pressure. D. Act as a uterotonic like oxytocin. Answer: B. Rationale: TXA inhibits fibrinolysis and stabilizes clots to reduce bleeding. Strategy tip: given early in severe PPH to reduce mortality when bleeding is significant. Question 37. Which medication is not recommended for tocolysis beyond 34 weeks gestation? A. Nifedipine. B. Terbutaline. C. Indomethacin. D. Magnesium sulfate, for neuroprotection, is used less than 32 weeks. Answer: B. Rationale: tocolysis has limited benefit late in pregnancy. Terbutaline especially is not recommended for prolonged use and has maternal cardiac risks. Strategy tip: tocolytics have gestational age limits and risk/benefit must be considered. Question 38. A pregnant woman with bacterial vaginosis in labor needs intrapartum antibiotics to prevent neonatal GBS sepsis. The drug of choice for penicillin-allergic patients with high-risk anaphylaxis is A. Cefazolin. B. Clindamycin, if susceptibilities allow, or vancomycin if not susceptible. C. Ampicillin. D. No antibiotics indicated. Answer: B. Rationale: for GBS prophylaxis in penicillin-allergic patients with high anaphylaxis risk, use alternatives like clindamycin if isolate susceptible, or vancomycin. Strategy tip: always check allergy and organism susceptibilities for intrapartum prophylaxis. Question 39. A woman at 34 weeks with preterm premature rupture of membranes receives betamethasone. How does this medication benefit the fetus? A. Lowers maternal BP. B. Enhances fetal lung maturity and surfactant production. C. Increases fetal movement. D. Prevents preterm labor entirely. Answer: B. Rationale: corticosteroids accelerate fetal lung maturation, lowering RDS risk. Strategy tip: given between 24 to 34, and sometimes up to 37, weeks for anticipated preterm birth. Question 40. Which drug should be immediately available when giving prostaglandin E2, dinoprostone, for induction? A. Terbutaline, tocolytic, to treat hyperstimulation if needed. B. Calcium gluconate. C. Naloxone. D. Protamine sulfate. Answer: A. Rationale: prostaglandins may cause uterine hyperstimulation. Tocolytic, e.g., terbutaline, may be needed as rescue. Strategy tip: have tocolytics and emergency supplies ready when using prostaglandins. Question 41. A patient in labor received oxytocin and is noted to have water intoxication, hyponatremia, headache, confusion. How can oxytocin contribute to this? A. Oxytocin has ADH-like effects and large volumes of hypotonic 4 fluids with infusion can precipitate hyponatremia. B. Oxytocin directly increases sodium excretion via kidneys only. C. Oxytocin causes hypernatremia, not hyponatremia. D. Oxytocin causes diabetes insipidus. Answer, A. Rationale: oxytocin is structurally similar to ADH. Combined with hypotonic fluids, it can lead to water retention and hyponatremia. Strategy tip: monitor fluid balance during prolonged oxytocin infusion. Question 42. A newborn with respiratory depression after maternal opioid administration is given naloxone. Which is true? A. Naloxone is contraindicated in neonates. B. Naloxone reverses opioid-induced respiratory depression in the neonate but may precipitate withdrawal if the mother is opioid dependent. C. Naloxone will improve neonatal hypotension unrelated to opioids. D. Naloxone should be given to all neonates at birth. Answer, B. Rationale: naloxone reverses opioid effects. Use with caution if chronic maternal opioid use causes neonatal withdrawal. Strategy tip: evaluate maternal opioid history before giving naloxone to newborn. Question 43. Which maternal vaccine is specifically recommended during each pregnancy, ideally at 27 to 36 weeks, to protect the newborn? A. Influenza only. B. Tdap, tetanus diphtheria pertussis. C. MMR. D. varicella. Answer, B. Rationale: Tdap in each pregnancy provides passive antibodies to protect neonates from pertussis. Strategy tip: administer between 27 to 36 weeks for optimal antibody transfer. Question 44. A postpartum woman with history of seizure disorder is on valproic acid and breastfeeding. What is the best nursing consideration? A. Stop breastfeeding due to teratogenicity concerns only for fetus. Postpartum exposure is low. Discuss risks and benefits with provider. B. Valproic acid is absolutely contraindicated in breastfeeding mothers. C. Give extra pyridoxine to the infant. D. Formula feed only. Answer, A. Rationale: many anticonvulsants are excreted in breast milk, but breastfeeding decisions should weigh maternal seizure control versus infant exposure. Valproate is generally compatible but requires monitoring. Strategy tip: coordinate with neurology and pediatric team for individualized advice. Question 45. A patient with severe preeclampsia is started on magnesium sulfate for seizure prophylaxis. Which of the following should the nurse include in care? A. Continuous fetal monitoring, strict INOS, hourly respiratory checks, DTR assessments, and have calcium gluconate available. B. Discontinue blood pressure monitoring. C. Encourage patient to ambulate frequently. D. Stop antihypertensives while on magnesium. Answer, A. Rationale: magnesium therapy requires close monitoring to detect toxicity and assess fetal status. Strategy tip: keep calcium gluconate at bedside. Question 46. Which medication is used to treat uterine atony when first-line uterotonics fail and is effective in preventing blood loss by vasoconstriction of uterine vessels? A. Terbutaline. B. Methylorgonavine, methergine. C. Ondansetron. D. Magnesium sulfate. Answer, B. Rationale: methylorgonavine causes uterine contraction and vasoconstriction, used for refractory atony, and less hypertensive. Strategy tip: check BP before administration. Question 47. A woman with severe postpartum hemorrhage receives high-dose oxytocin and then methylorgonavine, but bleeding persists. The next uterotonic often considered is A. Carboprost, Hemabate, and less contraindicated by asthma. B. Misoprostol is never used. C. Terbutaline infusion. D. Magnesium sulfate bolus. Answer, A. Rationale: carboprost is potent for refractory PPH but contraindicated in asthma. Misoprostol is also used but carboprost is commonly next line. Strategy tip: no contraindications for each uterotonic. Question 48. A pregnant patient with pre-existing hypertension is on ACE inhibitor therapy and becomes pregnant. The nurse should advise: A. Continue ACE inhibitor throughout pregnancy. B. Discontinue ACE inhibitor and switch to pregnancy-safe antihypertensive, e.g., labetalol, methyldopa, due to fetal renal toxicity risk. C. Double the ACE inhibitor dose. D. Add diuretics. Answer: B. Rationale: ACE inhibitors cause fetal renal dysplasia and are contraindicated in pregnancy. Switch to safer alternatives. Strategy tip: review preconception and early pregnancy meds for teratogenicity. Question 49. Which medication is administered to the newborn to prevent hemorrhagic disease of the newborn, vitamin K deficiency bleeding? A. Erythromycin. B. Vitamin K, phytonadione, intramuscularly shortly after birth. C. Hepatitis B vaccine. D. Rogum. Answer: B. Rationale: newborns receive IM vitamin K to prevent bleeding due to low vitamin K stores. Strategy tip: administer within the first hours of life per hospital protocol. Question 50. A patient at 30 weeks with severe preeclampsia is given magnesium sulfate for neuroprotection of the fetus. For fetal neuroprotection specifically, magnesium is indicated primarily at which gestational window? A. Greater than 37 weeks. B. Between 24 and 32 weeks, commonly up to 32 weeks for neuroprotection. C. First trimester only. D. At term only. Answer: B. Rationale: antenatal magnesium for fetal neuroprotection, reducing cerebral palsy risk, is generally used for anticipated preterm birth before 32 weeks. Strategy tip: no indications of magnesium, seizure prophylaxis, mother, and neuroprotection, fetus, in specific gestational ranges. You made it through all 50 of the toughest OB and maternity drugs for the NCLEX, and that's huge. Remember, mastering medications equals mastering NCLEX success. If this video helped you, don't forget to like, subscribe, and share it with another future nurse who's grinding for their dreams. Drop a comment below with your score or the drug you always mix up, and I'll include it in the next NCLEX You Can't Forget series. Keep pushing, keep believing, and I'll see you in the next one.